Thank you, Raghu. Good afternoon to all of you. So my remit today is to highlight the various aspects of lid reconstruction in the setting of trauma. I shall elaborate on the acute management of a patient with injury to the eyelids, goals and principles of lid reconstruction, some of which have already been discussed, and finally the management of lid lacerations or lid trauma with or without lid defects. So what is different in lid reconstruction in the context of trauma is commonly the presentation is quite acute and you're faced with a distressed patient with a surgeon who is faced with a challenging situation, frequently out of hours. There may be associated life-threatening or sight-threatening injuries, presence of possible foreign bodies or orbital involvement. And what is required in this situation is prioritization, a systematic approach, often liaising with your colleagues in other specialties with an emphasis on quick decision-making in that situation. Approaching an acutely injured eyelid, the first steps are, as mentioned, exclude life-threatening injuries, presence of globe injury or orbital involvement. A thorough history allows you to find out the mode of injury and suspect foreign bodies. In that situation, keep a low threshold for imaging, which is in most cases a CT scan. Some cases, more complex ones and those involving critical structures may need general anesthetic and appropriate arrangements need to be made for that, apart from tetanus prophylaxis and antibiotics. And this is a good time to take a clinical photograph if possible. An Excel examination begins with evaluating the extent of the injury, the depth, the presence of any infection or grossly devitalized tissues, any foreign bodies, involvement of the lacrimal system, orbital involvement, and most importantly, any lag of thalamus or exposure of the globe. Timing of repair is generally best done within the first 24 hours of primary repair. Sometimes you may have to delay it by a few days to control infection or inflammation, and secondary repair is generally poorer in its outcome. Injuries without tissue loss may either be margin sparing, margin involving, or sometimes classified as simple ones or more complex lacerations. Simple margin sparing lacerations can be closed in layers as shown here, with an emphasis on eversion of the wound edges and use of interrupted sutures. More complex lacerations may require the wounds to be brought back in position, aligning them as best as possible with anatomical landmarks. The classic technique for repair of a lid margin laceration involves the use of 3 non-absorbable 6/0 sutures, classically placed in this fashion through the posterior lid margin, the gray line, and the anterior lid margin, with further repair done, and the tails of the margin sutures tucked into the anterior sutures. An alternative in this regard is the diagonal suture lid margin repair, using a single absorbable 6/0 vicryl suture, which is passed from the about 3 millimeters inferior or away from the anterior tarsal surface, and the needle then comes out at the posterior lid margin and then engages the posterior lid margin again on the opposite side with a mirrored site of exit. This is a video showing the same technique. This is courtesy my colleague, Mr. Richard Caesar. This is the site of entry of the needle antero-inferiorly for the lower eyelid, coming out at the posterior lid margin and then going back into the posterior lid margin at the supero-posterior aspect of the tarsal plate. And finally, this brings the two ends together, and further repair of the tarsal plate and the wound is done in layers. This avoids suture abrading the surface of the eye and is superior in that sense. Associated levator disinsertion or injury should be looked for, particularly if you find fat within the wound, which is an indication of septal damage. Associated canthal tendon injuries need to be repaired at the same time, if possible. Sometimes very innocuous looking wounds may harbor quite sinister foreign bodies in the orbit, and when in doubt, always image. In this case, this was part of an e-cigarette or a vape which was removed from the orbit. Canalicular injuries commonly are suspected when there is a full thickness lid margin laceration medial to the punctum, and the lower canaliculus is more commonly injured. Early repair is desirable, and delayed repair till 5 days is acceptable. This is an example of the same. Lid margin laceration, exposure and identification of the distal cut end, and repair with mini Monoca stent, end-to-end apposition of the canalicular ends, and a repair of the lid margin repair, resulting in a good outcome. Finally, the reconstruction of lid trauma with tissue loss or lid defects is similar to the reconstruction with, from other etiologies, as has been already covered by my colleague. So the principles remain the same. With non-marginal anterior lamellar defects, it's preferable to convert them into an ellipse as far as possible and respecting Langer's lines. An alternative that has been described is the magic suture proposed by Thaler and Vadani, which essentially is a deep subcutaneous suture, bringing the edges, the wound edges closer together, with an emphasis on the direction of suture to be parallel to the lid margin at all points, as shown in the diagram here. And with this technique, they propose, they have shown reasonably large defects to be made quite much smaller and amenable to closure. An alternative is always full thickness skin graft. And when nothing works, just leave it to nature and using the laissez-faire approach. This is a picture showing areas on the face which are most amenable to a laissez-faire approach, with the green areas being most favorable. Small full thickness defects can be closed by direct closure, technique of which has been discussed, further augmented with a lateral canthotomy and cantholysis. Another example of the same. Moderate full thickness defects require techniques such as Tenzel's or McGregor's advancement flaps, apart from other combination of other flaps and grafts. This has already been covered before. The Tenzel's advancement flap, a myocutaneous flap which allows for closure of a moderate lower lid defect. An alternative to that is the McGregor's flap, which involves a Z-plasty to effect tissue lengthening along the lid margin. Larger defects, near total full thickness defects, generally employ lid sharing procedures apart from non-sharing procedures, which my colleague shall probably emphasize on. This is a pictorial description of the Cutler-Baird procedure, which is employed for an upper lid defect using a flap from the lower lid. This is an example of the same, a defect in the upper lid. Posterior advancement flap accompanied by a middle lamellar graft, which in this case was banked sclera. Completion of the graft, of the flap, and then finally post-division. A similar flap for lower lid defects would be a Hughes flap. Example of a defect in the lower lid, closed with a Hughes flap, and the picture post-division. Example of another Hughes with anterior lamella being repaired with full thickness skin graft instead. At times, one is faced with rather challenging situations, as was in this case with a lady who fell unconscious in her kitchen and apparently fell over her dog, who then proceeded to attack her and bit off most of her face, including the nose, the upper lips, but more importantly, resulted in a situation with complete loss of the upper and the lower lids, resulting in challenging situation for repair, but also something that needed quick temporizing measure to cover the globe. What I used in this situation was the masquerade procedure, wherein Fornical conjunctiva was identified and drawn towards the midline, sutured in the midline, and then advancement flaps from the forehead and the cheek was advanced to cover the entire globe, thus protecting the globe. And then a second procedure done a few weeks later to create a small slit opening, thus allowing the lady use of her eye, although a small amount of phimosis has happened subsequently, which needed further repair. But she retains good use of the eye and is 6/6 in the eye. So to summarize, in adnexal trauma, having a stepwise systematic approach and being able to prioritize appropriately is key. Keep a watch for lacrimal system injuries and foreign bodies to make sure you don't miss those. Following the basics, which have already been described earlier, of flaps and grafts is essential. And sometimes, particularly in cases of trauma, use techniques to protect the globe and temporize if needed. Thank you for your attention.
Thank you so much, Prashant. That was really very enlightening. And excellent overview over all the intricacies of traumatology in our